Hi everyone, my name is Meghana Pagadala and I'm an MD PhD student at UCSD, co-mentored by Drs. Hannah Carter and Jill Meserov. And today I'll be presenting my research titled PRState, Incorporating Genetic Ancestry in Prostate Cancer Risk Scores for African American Men. Cancer is a devastating diagnosis. It is the second leading cause of death and comes with an increased financial burden, as cancer patients are 2.5 times more likely to declare bankruptcy as healthy people. This is partly due to the fact that cancer is an extremely complex disease, marked by several inter- and intra-individual differences that lead to variable responses to conventional therapy such as chemotherapy, radiation, and surgery. Instead of this one-size-fits-all approach, precision medicine aims to optimize outcomes using lifestyle information, genetic profiling, and environmental exposure information. Genetic profiling in particular is important for cancer, as cancer is a genetic disease, marked by mutations in key genes that lead to the hallmarks of cancer, such as uncontrolled proliferation, immune evasion, and genetic instability. Genetic risk scores in particular are useful clinical tools for screening cancer risk and require germline information that can usually be acquired in a cost-effective manner. Risk scores are usually constructed by first identifying risk variants in genome-wide association studies of large populations of patients with and without cancer. These risk variants can then be summated into a single score, weighting them by the effects that they have on their cancer, and used to stratify cancer risk, where individuals with cancer typically have an increased score compared to individuals without cancer. Although genetic risk scores are effective clinical tools, they are usually constructed from European GWAS studies, limiting their applicability in other populations, such as African Americans. This is especially apparent with prostate cancer, as prostate cancer disproportionately affects African American men, as they have a 1.6 and 2.4-fold increased risk of prostate cancer diagnosis and age-matched mortality compared to men with a European ancestry. Furthermore, prostate cancer is a highly heritable cancer with a heritable component of 57%, suggesting that genetics plays a large role in prostate cancer risk. However, currently, the genetic risk scores applicable for African American men is limited, and we need more research to improve this. Thus, for this research, we wanted to better understand how genetics contribute to prostate cancer risk in African American men, and to develop an African ancestry-specific polygenic risk score. To do this, we first started off by identifying an African discovery cohort in the LIPS consortium, which is composed of 91,644 men with or without prostate cancer. We then used FROG-KB to determine European and African ancestry likelihood for all individuals, using 55 informative markers. We then used likelihood thresholds such that the population size for our cohorts was maximized while minimizing admixture. For the African discovery cohort, we used an African likelihood threshold greater than -15 and a European likelihood threshold less than -15 in order to get a discovery cohort of 4,533 men. For the European discovery cohort, we used a European likelihood threshold greater than -10, resulting in a cohort of 5,567 men. We then ran associations with prostate cancer status in the African discovery cohort to identify 10 significant associations that were African ancestry specific on chromosomes 3, 8, and 11, and we controlled for age and principal components. We then analyzed the effects of these African ancestry-specific prostate cancer risk variants in the African ancestry cohort, the European ancestry cohort, and our mixed trans ancestry cohort, and found that the effects of these variants were particularly stronger in the African ancestry cohort compared to the European ancestry cohort. After identification of these African ancestry-specific prostate cancer risk variants, we then constructed a polygenic risk score with these 10 variants and called it PRState. We then evaluated the performance through an ROC-AUC analysis and achieved an ROC-AUC of 0.65 when we combined it with age and family history, which are other big factors in predicting prostate cancer risk. As we can see from this quantile plot, in addition, when we stratify by the PRS quantile, we see that the odds of prostate cancer also increase, which suggests that PRState does a good job in stratifying prostate cancer risk in African American men. In comparison, we constructed a polygenic risk score from prostate cancer variants identified through analysis of our European discovery cohort, and we're only able to achieve an ROC-AUC of 0.59 in the African discovery cohort when combined with age and family history. This was significantly lower than the polygenic risk score that we constructed specifically for African American men. Furthermore, when we look at the quantile plot, we see that a European ancestry-based polygenic risk score does not do as well in stratifying prostate cancer risk in African American men. This suggests that using an ancestry-matched polygenic risk score boosts performance compared to using an ancestry-mismatched polygenic risk score. Since a number of multi- or trans-ancestry association studies with prostate cancer have been conducted, we wanted to evaluate whether trans-ancestry analysis could recover some of the signal and predict prostate cancer risk in African American men. Indeed, when we construct a polygenic risk score from trans-ancestry prostate cancer variants that we identified from the ELLIPSE consortium, we are able to achieve an ROC-AUC similar to the one that we achieved for the African ancestry-specific polygenic risk score, and the ROC-AUC was approximately 0.66. Next, we wanted to evaluate how our African ancestry-specific PRState score did in comparison to existing genetic risk scores for prostate cancer. So to do this, we evaluated a model with our PRState PRS and then a Conti PRS, which is based on a recently published multi-ancestry study of prostate cancer. We note that some of the variants that we identified were also identified by this study, and so we excluded it when constructing the Conti PRS. And then we combined both of these PRSs with age and family history. And what we find in our ROC-AUC analysis is that we achieved a significantly higher ROC-AUC when we combined both our PRState PRS and the Conti PRS in comparison to the Conti PRS only or the PRState PRS only. We next evaluated our PRState score and the Conti PRS in an external validation cohort. We used the Million Veteran Program, which has genetic information and prostate cancer information for over 500,000 veterans. Doing this, we were able to achieve significantly higher performance in predicting any prostate cancer and metastatic prostate cancer when we combine both the Conti and the PRState PRS compared to either one alone. We did not achieve significantly higher performance in predicting fatal prostate cancer or death from prostate cancer, though. Additionally, we found with our PRState score that we achieved higher ROC-AUC in predicting any prostate cancer, metastatic prostate cancer, and fatal prostate cancer in African American men compared to men of European ancestry. So to conclude, we identified 10 African ancestry-specific prostate cancer associations in the ELLIPSE consortium, and using this, built an African ancestry-specific polygenic risk score called PRState that achieved an ROC-AUC of 0.65 when combined with age and family history. We furthermore showed that ancestry-matched polygenic risk score models perform better compared to ancestry-mismatched models in predicting prostate cancer risk in African American men, and that our PRState score boosted prostate cancer prediction in African American men when combined with existing genetic risk score models. Lastly, we validated the score in the Million Veteran Program, not only showing its utility in predicting prostate cancer risk, but also high-risk metastatic prostate cancer risk. And it performed better in African American men specifically compared to European ancestry men. So with that, I would like to thank both of my labs, the Carter lab and the Meserov lab, and my two mentors, Jill Meserov and Hannah Carter. I'd also like to thank the MVP 22 working group, which was very helpful for external validation of the PRState score. And I'd also like to thank Stephen and Dr. Cater specifically, who were the urologists that I worked with for this study. So with that, please feel free to email me if you have any questions. Thank you.